Another question, Dr. Johnson, when you're looking at, we've talked about the hard data where the benefit is there, either, equivalent or it may be superior in some of the risks that we would have come about with the DOACs. But what are some specific challenges that you recall that, you have faced with making that treatment decision with DOACs in the obese population?
Well, I think the challenge was, initially, and I'm talking about a few years ago, as we get these extreme, especially the BMI over 40, the concern that maybe we haven't studied enough or we don't have enough data out there to safely prescribe a DOAC in that instance. The difficulty we had was with these patients, all the things we've talked about with diet, interactions, was trying to maintain someone in therapeutic range that has all those variabilities. And, as we get to the morbid obese patient, you have a lot of other drugs most of the time that these patients are taking and the interactions. And so clinically, the difficulty I had was frustration from the patient and the practitioner of trying to keep someone anticoagulated with warfarin. And so even early on, when we started to see the data coming out with some of these BMI in that 35 to 40 range and even above 40, clinically, we started to get a comfort level using, especially rivaroxaban in those patients. And I think just like we were talking about with the renal insufficient patients, as we got more and more data with the renal insufficient patients and seeing the efficacy and the safety in the data there. And just like Paul had mentioned earlier, that's probably just as important or more important as the safety for these patients. The safety data continues to shine through.
Paul, you talk about, some of the newer data that's coming out or that has come out recently, with all the clinicians going in different ways with different responsibilities, what is or how do we make our colleagues aware of this particular data? And have you found a trick to your trade to kind of help on that education side with detailing those prescribing providers and even, your pharmacists that are, on the front lines with giving education to their own patients?
Sure. You kind of hit on the term there. It's education, education, education. Because, a lot of busy practitioners are really kind of, down deep into patient care. And, and so the luxury of my job is I have time to evaluate these trials, and my job is to do this education. So, it's things like, making sure you're on the residents, periodic teaching round, grand rounds that happen. And, you're bringing these topics up there. When you're on service, then, you're more in tune. If you could put together, one-page summaries that maybe get circulated around the pharmacy, or, I work a lot with the cardiology department. And so, maybe kind of try to circulate stuff there. But things take time, right? Change doesn't happen quickly. We know that. Just remember, these drugs have been out now for, 10 years. And just recently, the use has overcome that of warfarin. There's more people get DOACs now than get started on warfarin. That just happened like 2 years ago. And so change happens slowly, and we just have to be advocates and, keep at it, entertain good discussions like this, right? Creating educational materials like what we're doing here this afternoon. This has the ability to influence, hopefully, or educate, thousands of people. And so these are great venues in which these types of messages can get out, and then people can just, bam, now we're going to take better care of this group of patients.